And together, we will move mountains. And if they don't hear our message, then we'll just do it over and over and over and over 1,000 times again for you.
And I'll rise up, I'll rise like the day, I'll rise up in spite of I will rise, we will rise, we will rise, we will rise.
Hello, my name is Michelle Zabel and my pronouns are she and her. I'm an assistant dean at the University of Maryland School of Social Work and the proud director of the Institute for Innovation and Implementation. Today, I'm just delighted to welcome you to this Training Institute live workshop. As you might have come to expect with all your favorite conferences, the Training Institutes are now virtual. And although I know we'd all like to be together in person, we are excited to host the virtual Training Institutes and really want to encourage you to continue to join us on the first Thursday of every month through August. Each month, you'll have a choice of 2 back-to-back workshops. So mark your calendars, choose your workshops, and make sure you reserve your place early so that you can attend the workshop that most interests you. Today, I want to encourage you to actively participate by using the chat to post your questions. Post your comments and share your resources with your colleagues. Our presenters, they definitely want to hear from you. And it is absolutely your participation that will make each of these sessions a success. As a reminder, staff are monitoring the chat and they're going to make sure the facilitators see your questions and comments, so be sure and engage. A few other reminders to include: if you need assistance at any time navigating through these virtual spaces or accessing links to workshops, we do have a live help desk support standing by to assist. We are also providing a certificate of attendance after the completion of each workshop, and all of our workshops are being recorded, so by you participating, you're implying consent. Finally, there will be an ASL interpreter or closed captioning available during each workshop. Those interpreters can be pinned when available for those who require interpretation by hovering over the interpreter's video and selecting the 3 dots. One of the options that will appear is Pin Video. By selecting the Pin Video, this video will not move out of view. Following the workshop, we will have a wellness and mindfulness break with guided activities before our second afternoon session. With our theme, What Could Be? Bolder Systems and Brighter Futures for Children, Youth, Young Adults, and their Families, all of our sessions will challenge us to envision a future where the voices of children, youth, young adults, and their families are elevated, especially those who are most frequently silenced or marginalized, where we use the best data and research available to challenge ourselves, developing new ideas and approaches that can be implemented to meet the needs of youth and families, and in service of our commitment to social justice and the elimination of disproportionality and disparities. My hope is that today's session will provide you with food for thought as you consider your next steps in creating a vibrant, equitable future for youth with complex needs and their families. Please don't forget to register for next month's workshop. Remember, they're held the first Thursday of every month, and you can visit the institute.umaryland.edu for the full schedule. Thank you so much for joining us, and I look forward to seeing you next month.
Good morning, everyone. Good afternoon for those of you on the West Coast. My name is Stuart Gordon. I am the former Senior Director of Policy and Communications, now retired, at the National Association of State Mental Health Program Directors. I'm going to lead off the discussion today. I'll be followed by Dr. Christian Savicki, a Child Clinical Systems Team at the Office of Behavioral Health in the Louisiana Department of Health, and Kristen will be followed by Eric Tadahara, Assistant Director of Children's Behavioral Health at the Utah Division of Substance Abuse and Mental Health. Next slide, please. Next slide, please. As I think you all know, there was a Commonwealth Fund study that came out towards the end of last year that reported a 60% reduction in outpatient care for all clinical specialties early in the pandemic in April. Medicaid and Medicare acted quickly to fill gaps in access through telehealth, authorizing flexibilities through a March 13 declaration of the Stafford Act. That's a federal law that allows for the declaration of public health emergencies. They used that declaration to implement a waiver declaration that had been issued by HHS Secretary Azar on January 31st. The Commonwealth Fund study found that telehealth initially had a peak in April, slowly declined in ensuing months. By September, the outpatient visits had rebounded and were beginning to climb again, but there were behavioral health provider visits, outpatient visits were still about 14% below the March volume. And for all providers, the use of telehealth continued to be well above pre-pandemic levels. A Fair Health study issued earlier this week found that in February, telehealth visits made up less than 10% of mental health care services for patients ages 19 to 22, but by November, telehealth visits were 70% of mental health care services for those same patients. The American Rescue Plan, HR 1319, and everything you see linked here can be accessed through the link when you get copies of the slides. Passed by this House on Saturday, now currently being considered by the Congress, includes grant monies for rural, Native American, and state, local, tribal, and territorial governments, tribal organizations, and nonprofit community-based entities, as well as primary care and behavioral health organizations that would be used to expand telehealth. Next slide. The CMS division governing Medicaid and CHIP programs issued an informational bulletin to state Medicaid agencies last April 2nd on ways that telehealth services could be implemented. Again, that bulletin's linked here. It clarified that states have broad flexibility in designing their parameters for telehealth delivery of services, as long as those services are consistent with the overarching provisions of the Social Security Act, the Medicaid provisions of Social Security Act, the state's state plan, and any policy framework. They can also use their Medicaid MCOs to deliver services via telehealth through those managed care contracts. The CMS clarified that a state plan amendment is not necessary to incorporate telehealth delivery if there's no changes to the services description, limitation on the services, or changes to reimbursement for the services as telehealth services. However, an SPA is necessary if there are specific distinctions for coverage or different reimbursement methodologies for use of telehealth. Next slide. A 2019 CMS review of laws and Medicaid policies in all 50 states and DC found that all states and DC had some form of reimbursement in 2019 for services delivered by telehealth. The predominant form was live video, but 14 states reimbursed for store and forward. 22 state Medicaid programs had some form of reimbursement for remote patient monitoring. 19 explicitly allowed homes and schools to serve as originating sites, although very often there were additional geographic or specialty restrictions. The information bulletin offered state examples in the next slide of Idaho, Georgia, and Kentucky. Next slide, Eric. I'm going to leave those for you to review later. Next slide. In early June of last year, SAMHSA requested that my organization and the National Association of State Drug state alcohol and drug abuse directors obtained feedback from states on what flexibilities they'd like to see maintained after the public health emergency, and specifically telehealth flexibilities. They wanted feedback on telehealth. State agencies solicited feedback from their providers. Maryland, kudos to Maryland. They sent us responses from 240 providers in a spreadsheet. Reports from states indicated that the use of telehealth and audio-only phone calls, which I'll mention in a second, to provide services had proven overwhelmingly beneficial. Next slide, please. Those benefits included clients with transportation needs generally, and those fearful of the dangers of COVID-19 infection, traveling on public transportation. Benefits were also seen for clients in rural areas lacking nearby providers who normally had to travel significant distances for a face-to-face session. Individuals with severe anxiety or disorders or agoraphobia for whom travel in a vehicle or in public places was extremely difficult. Individuals feeling more comfortable sharing their feelings and thoughts via telehealth or audio-only telephone than in person. Individuals fearing COVID-19 infection during face-to-face encounters. Individuals fearing stigma from seeking treatment in a more public arena. Clients with disabling co-occurring conditions such as cardiopulmonary disease that might otherwise have negatively affected their ability to travel to treatment. Children who, prior to the pandemic, had received counseling in school-based counseling sessions that were no longer available with schools closed, but were able to continue their therapy at home through telehealth. Clients in crisis afraid to leave the home to seek help, fearing involvement with law enforcement, and clients who had themselves contracted COVID-19 and were in quarantine. Next slide. It was among the benefits that were reported was a significant decrease in missed and canceled appointments. States estimated that decrease was on average about 10%, but at least one state mentioned as high as 40%. It was an upward trend in the number of client sessions due, at least in part, to clinician capacity and availability being increased as a result of the elimination of transportation time for both providers and clients, an increase in the number of family therapy sessions and family wraparound meetings due to the fact that the family no longer needed to be gathered together in the family van to take them to the session, an increased ability to maintain contact with family members during the pandemic for individuals in socially isolating residential treatment. Those remaining in the workforce were able to circumvent scheduling conflicts created by work schedules and childcare demands, and forensic evaluations were made more efficient as travel time was eliminated for the provider. That in turn resulted in shorter wait for evaluations and eliminated some backups in evaluations. Next slide. They also reduced the rates of readmission to psychiatric hospitals because of the ready availability of treatment. For providers of children's services, it provided an opportunity to view and engage the client in his or her own environment and in interactions with family members that might not otherwise be visible in an office environment or a more public environment. Therapy with elementary school children via telehealth proved to be more effective than expected, with clients reported to be making great strides in those sessions. Group therapy sessions like family therapy sessions were facilitated and better attended, because of therapists being allowed to hold sessions during evening hours not previously convenient. And other services were provided in the home environment made possible by telehealth, including medication management, psychosocial assessment, and diagnostic evaluation. Next slide. The telehealth also allowed for a better continuity of care. An inpatient or outpatient treating physician was more likely to follow their clients via telehealth, given the flexible scheduling options. It facilitated patient privacy, built patient autonomy and self-confidence, helped to alleviate the impact of provider shortages, which grew greater as the pandemic grew. and resulting waiting times, and made it possible to serve, in one state at least, individuals that were on the Medicaid wait list, allowed for the use of effective evidence-based tools through telehealth, such as assertive community treatment. One state reported that there had been a 50% increase in the use of ACT. While some respondents said that older clients found the telehealth technology challenging, not everyone found that to be so. One responded, and you can see the quote here, that it empowered those older individuals, gave them more motivation and confidence for continued change in their lives. Next slide. Audio phone based services were authorized under the waivers. They provided an alternative for clients who either did not have access to video technology or may have been wary or simply preferred phone technology because of body image concerns or concerns about risks to privacy, or because they might have found it easier to open up on a phone than in a face-to-face session. Again, they were audio only was found to be instrumental in engaging the older populations that may not have been as familiar with the internet and video technologies. Moving on to Medicare in the next slide, while state Medicaid programs were historically flexible and gained additional flexibilities by CMS waiver during the public health emergency, Medicare had been historically less flexible, restricting the originating site in particular. However, over the previous 2 years prior to 2020, CMS had expanded the ability for clinicians to bill Medicare for virtual check-ins through phone, video chat, and online patient portals. Beginning in March of 2020, during the pandemic, CMS announced it would temporarily pay all clinicians to provide telehealth services, regardless of the originating sites, and that they would be paid at the same amount as for face-to-face services under the Medicare physician pay schedule. Additionally, the HHS Office of the Inspector General provided flexibility for healthcare providers to reduce or waive cost sharing for telehealth visits paid by Medicaid and Medicare without being accused of ethical violations. Next slide. The March 13th emergency declaration allowed CMS to further loosen the existing restrictions under Medicare. A range of healthcare providers, and you can see those listed here, were able to offer telehealth in any healthcare facility, including a physician's office, a hospital, a nursing home, or a rural health clinic, as well as from the patient's homes or the provider's home without violating the Medicare originating site restrictions. There were a number of guidance and interim final regulations issued over those ensuing months. The interim final regulations issued March 31st allowed payment for the audio-only telephone evaluation and management services as a substitute for office or outpatient E&M services. At the time, CMS called for all private insurance companies to also expand and clarify their policies around telehealth. Next slide. In a subsequent interim final set of interim final regulations issued just a week later, April 6th, with comments due in June, CMS modified the process for adding or deleting additional services from the Medicare telehealth services list outside of the regular rulemaking process. As of January 2021, CMS, these additional telehealth services were to be for the public health emergency. As of January 2021, CMS had added about 140 services to a telehealth services list. There's a bit of confusion here. They have been saying that there were 144 services added. The services list, which is in a spreadsheet, which you can access through this link, shows about 138. At the time, the public health emergency was due to end on April 20th of this year, but the Biden administration indicated in a letter to governors issued on January 23rd that it plans to eventually extend the public health emergency until the end of 2021 via a series of 90-day extensions. CMS will provide the states with 60 days notice prior to termination of the public health emergency. The Medicare program issued its proposed, as it does every year, physician fee schedule and quality payment program regulations for the 2021 benefit year on August 3rd. And in those regulations, they proposed to permanently add 9 reimbursement codes for telehealth services that match flexibilities that had been provided during the PHE. And they added temporarily other reimbursement codes for telehealth services through the end of the PHE. Those temporary codes were subject to public comment. They're collecting comments. They were collecting comments on the clinical benefit of each of those services delivered through telehealth and the potential harm to patients. It did not propose adoption under any category of adoption for audio-only telehealth services, stating that it lacked the legal authority to do so without a congressional change to the law. Now, that was in the August 3rd proposed regulation. In the final regulations issued December 1st for January 1, they announced a commission study of telehealth flexibilities provided during the PHE. The Office of the Inspector General put out its projected work list for the next few months, for the next quarter. They are conducting at least 7 different national audits, evaluations, and inspections of telemedicine services under Medicare and Medicaid programs. And one of those audits will analyze how state Medicaid programs and MCOs use telehealth to provide behavioral health care. The federal final regulations also added 60 telehealth services on a permanent basis, but those added services were only for rural beneficiaries. On the next 2 slides, I've laid these out, some codes that you can see. The first slide are telehealth services that were added on a permanent basis. The following slide are telehealth services under what's called Category 3 on a temporary basis until the end of the public health emergency. The December 1 final regulations allowed licensed clinical social workers, clinical psychologists, physical therapists, occupational therapists, speech-language therapists to furnish brief online assessment and management services called virtual check-ins in order to facilitate these virtual check-ins. They established 2 new reimbursement codes. They stated in the final rule that the telehealth rules do not apply when the beneficiary and the practitioner are in the same institutional setting but are physically separated to minimize exposure risk. So for you to be reimbursed for telehealth delivered services, both the provider and the patient have to be in separate locations, even if audio-video technology assists in furnishing the services. Next slide, please. Audio-only telehealth remains covered only until the end of the public health emergency or until December 31, 2021. CMS recognized the need for audio-only interaction to avoid sources of potential infection, such as a doctor's office, and recognized that in that circumstance, a longer phone conversation might be needed to determine if an in-person visit is necessary, but the agency said it was unable to permanently waive the statutory requirement that telehealth services be interactive telecommunication through a 2-way audio-video communication technology. They did seek comment on whether audio-only coverage should be continued beyond December 31 of this year. In a hearing that was held in the House Energy and Commerce Health Subcommittee on Tuesday, one of the witnesses, Dr. Ativ Mehrotra from Harvard Medical School, suggested a 1 or 2 year glide path for study before audio-only, to allow audio-only to continue until broadband had been sufficiently expanded, or for 2 years at least, before it be ended. In the December 1 final regulations, CMS established payment on an interim final basement for audio-only medical discussions under virtual check-in services emphasizing that this service, the virtual check-in, is not intended to be a substitute for an in-person visit. I think we all agree no one intends those services to be a substitute for a permanent substitute for an in-person visit. The general assessment is that they should be used on a rational basis, but not for every visit. Next slide, please. Does the law actually, as CMS suggests, require a legislative fix to the Medicare law by Congress for audio only to be made permanent? Well, the statute actually gives the Secretary authority every year to add additional services to telehealth services, to add additional codes as appropriate. Next slide. And CMS is pointing to a provision of the statute that allows only Alaska or Hawaii to use asynchronous transmission of healthcare information. They're interpreting that the exception for those two states to imply that no other states can use audio only. However, the general canons of statutory construction issued periodically by the Supreme Court don't bear that interpretation, absent explicit statutory language that no other state is allowed to use audio only or asynchronous transmission. And we argued that, as did the Mental Health Liaison Group, an advocacy coalition of about 70 organizations located in DC. In our final comments on those final regulations, CMS refused to budge from its previous interpretation of the statutory provisions. The next two slides show our argument. I think we've already laid those out. One, that the Secretary has the authority to add additional services to the telehealth list, and two, that the provision allowing Hawaii and Alaska to have asynchronous services does not necessarily imply that no other state can do so. Finally, the CMS snapshot on telehealth utilization. They released a preliminary Medicaid and CHIP data snapshot on telehealth utilization during the public health emergency. That revealed, and there have been no more recent snapshots, and I'm sorry about that, but that snapshot revealed that there were more than 34.5 million services delivered via telehealth to Medicaid and CHIP beneficiaries between March and June 2020. That represented a 2,600% increase over the same period for the prior year. The data also showed non-senior adults received the most services delivered via telehealth, although there was substantial variances across both age groups and states. Separate Medicare data announced by CMS on December of 2020 revealed, and this is Medicare data again, revealed that between mid-March and mid-October, over 24.5 million out of 63 million Medicare beneficiaries, that's 39% of Medicare beneficiaries, had received a telemedicine service. CMS also offered technical assistance to a supplement to its telehealth toolkit. There's a link here on this slide to that toolkit with some supplemental information intended to help states think how to explain and clarify to providers and stakeholders which policies are temporary and which are permanent, and how telehealth can be implemented, which providers can implement the services, ways that they can be implemented, and how they could be reimbursed. There's also a series of frequently asked corrections in that toolkit for your use. And now I'm going to turn it over to Kristen to discuss evidence-based practices in behavioral health in Louisiana.
Hi, thanks, Stuart. I'm Kristen Savicki with Louisiana's Office of Behavioral Health, and I'm going to be talking today about a small targeted effort that we've made here in Louisiana to support the move to telehealth by a specific group of providers. These are providers we've recently invested in through training in evidence-based programs in children's behavioral health. So first, a little background. We've recently been able, just in the past couple of years, to stand up our Louisiana version of what many states call their Center for Excellence. We developed the center as a partnership with our flagship public university, which now houses what we call our Center for Evidence to Practice. The center really got into the swing of things in 2019, serving as our statewide hub for training and implementation of EBPs for providers in the Medicaid provider network. Our aim with the center is to support the scale up of a menu of evidence-based behavioral health treatment models to improve outcomes for Medicaid insured children and families. Next. So our menu of established EBP programs under Louisiana Medicaid was until recently focused on just 3. So if you see that family systems interventions line there, those first 3, home builders, MST and FFT, those were the programs that we had on our EBP program menu for kids until very recently. And those are fantastic programs, but we wanted more. We wanted some expansion, particularly in a couple areas where we saw gaps, which include dyadic treatment for very young children and trauma treatments. So we've been slowly building up our menu of different types of EBP programs for different populations, different groups of kids, different presenting problems over the course of our collaboration in the last couple of years between our office, Louisiana Medicaid, and the Center for Evidence to Practice. Next. In some of the early work by the center in 2019, the center trained and supported over 160 providers throughout our state in the adoption and delivery of these evidence-based treatment models. So this is a workforce that we've just started to invest in, we're committed to, and we don't want to lose. As I'm sure folks are familiar, attrition rates for providers falling out of EBP training or certification are a constant concern for us, as they are for every other state we've talked to. Next. So then COVID hit. This impacted our work in countless ways. For one, almost exactly a year ago, I was sitting in a classroom in Baton Rouge, talking to a cohort of therapists gathered from all around the state who were starting their week-long initial training in PCIT. That same day, that Monday, Louisiana announced our first confirmed COVID case. And by Thursday, our governor had announced a public health emergency, and we had to send our group of therapists home a day early. COVID, of course, produced other and more ongoing problems. For one, we worked hard to build this emerging workforce, and we don't want to lose them. And even more pressing is that we have a lot of vulnerable kids and families under a lot of stress, and some of it new and unprecedented stress, and we didn't want them to lose access to the support they need. Next. So the story we saw at this point was one of overnight transformation. The Center for Evidence to Practice first informally gathered information from providers, then they did a larger survey of primarily child-focused EBP providers in the state. And our survey respondents reported a dramatic and fast shift to telehealth. This echoes a lot of what Stuart was telling us about the national trends as well. 90% of our child EBP providers reported continuing to serve kids during the pandemic and the stay-at-home order using telehealth. Next. This was borne out in the Medicaid encounter data as well. In the larger world of services to all Medicaid members, we saw a 6,000% increase in members served using telehealth. And the same trend is true for providers. We went from 50 providers a week using telehealth platforms to over 1,000 providers per week using telehealth platforms. Next. So for example, here are therapy services. So for context, Louisiana Medicaid already had policy in place pre-COVID, allowing for telehealth delivery of psychotherapy, the same reimbursement rate as in-person therapy. However, you can see that this option was rarely used prior to March 2020. So on this graph, each bar represents the total number of therapy claims by month, and all those blue bars are the months starting in January 2019 through February 2020. So you can see the blue represents in-person, non-telehealth delivery. It was pretty much 100% in-person, really no telehealth usage to speak of. Then in March, the story changes dramatically. We see that our total level of therapy utilization, so that's the overall height of each of these bars, did dip a little bit after the pandemic hit, but not by as much as we feared, and it bounced back pretty quickly. Instead, what we see is that providers continued to provide therapy to Louisiana Medicaid recipients. They just jumped quickly and dramatically to the use of telehealth delivery. So the change was most dramatic in April 2020, That's when, it started in March when our governor instituted a stay-at-home order. And then in April, we see that the level of therapy services delivered via telehealth jumped to 70%. 70% of all therapy claims were delivered via telehealth in April. And we continue to see this, I mean, in the data here through October 2020. So providers did slowly increase the proportion of their services that were provided in person as the months went on in 2020. But even by October, we were still seeing about half of all therapy services being delivered via telehealth. And my data folks want me to note here that I'm only showing data through October because that's the last time we have the complete set due to claims lag. Next. So some of our EBP programs, our intensive home-based programs like MST and FFT, were not previously allowable via telehealth, but we were able to put in new telehealth flexibilities for those programs as well when COVID hit. And we similarly saw providers turn on a dime, keeping kids and families connected to services through this new modality. Next. So, as the previous data shows, our providers already dove into the deep end with telehealth. So for us and our partners, we started to look at ways that we could support providers to not only use telehealth, because they're already doing that, but to use telehealth confidently and effectively. Going back to our EBP providers, it's one thing, and it's a really important thing, to do treatment as usual via telehealth. But if you're used to sitting in someone's living room and you're balancing engagement with arguing teens and parents and siblings to do functional family therapy, how do you do that over Zoom? Or if your practice is to work with a mom and a toddler together, repairing attachment damage by trauma using child-parent psychotherapy, how do you do that remotely? So we realized that there's some additional challenges that our EBP providers may face in figuring out how to deliver their EBP model to fidelity in this new way. Next. Our partner, the Center for Evidence to Practice, they saw this need and they jumped in. And this is one of my favorite innovations here. These are our EBP-specific telehealth trainings for providers. So the center partnered with local and national trainers in each of these EBPs to develop webinar training specific to that EBP, to teach and coach EBP providers on how to deliver the model in this new way. They developed and pushed out in a very short amount of time telehealth trainings via webinar for child-parent psychotherapy, for EMDR, for MST, for TFCBT. Next slide. And for DBT, and for PCIT, and for FFT, and for preschool and youth PTSD treatment. Next. And looking at the uptake of these webinars from providers, we think we see evidence that we're meeting a need here. So starting in April of 2020, a total of 582 providers around Louisiana have participated in these webinar trainings. I mean, the free CEUs probably didn't hurt. We were able to get some solid expert information out there to these providers very quickly with tips and guidance for how to shift their practices. Next. Another indication of the utility of these trainings is in the comments we received from participants. We saw lots of comments on appreciating the validation that they received by talking to other providers who were also trying to do this EBP in this new way. Increased confidence. This is just a whole new world that providers were stepping into, and we wanted to be able to support them in it. So as you can see from these comments, reports of just being good to talk to other people who are trying to do this difficult thing and getting some tips and tricks to feel a little more comfortable delivering these models in a new way. Next. So another thing we're doing for this emerging group of providers is to offer some financial support for their transition to telehealth. Our providers jumped into the use of telehealth, and at times they did use those emergency flexibilities, such as audio only that Stuart was talking about, to keep services in place for kids and families. That's great, but we want to support sustainable ongoing use of telehealth in the longer term, not only because the pandemic continues to stretch on, but also because we're all seeing the advantages. Much of them Stuart spoke to, the advantages of continuing robust use of telehealth even past the pandemic. So we want these providers to be sure they're using an effective HIPAA compliant platform that works for them, and that costs money. So to that end, we're using some of our SAMHSA emergency COVID grant funding for telehealth financial support grants for providers. Next. Through our partners at the Center for Evidence to Practice, we put out an RFA for providers who could apply for these support grants based on the criteria that they have to be serving Medicaid clients and they have to be providing an EBP from one of our menu of EBP services that we talked about earlier. Our goal was to provide a bit of financial support based on this new cost that might be a financial burden, especially for this group of providers, some of whom were just getting started with their EBP programs. Next. Our selected providers, many of whom are smaller, more rural providers, then went through additional offered training to sharpen their skills in the use of telehealth. And each provider agency has received one-on-one consultation with the Telehealth Certification Institute to help them review their options and select a telehealth platform that works for them. With that additional training and consultation as support, providers then prepare their telehealth business plans, outlining what telehealth technology they selected to purchase and how they'll integrate that and use it in their practices. Our partners at the Center for Evidence to Practice are now responding to these provider business plans and granting out funding to these providers to support the purchase and use of their selected telehealth platforms. So these are our strategies so far to target the small but growing group of providers to help them with the skills and the support and the confidence to deliver quality telehealth services to kids and families. And with that, I'll turn it over to Eric, who's going to share the work they're doing in Utah.
Thank you very much, Kristen. I'm Eric Tadahara. I work in the Utah Department of Human Services under the Division of Substance Abuse and Mental Health, and I'll give you a little snapshot of a telehealth pilot that we've actually been looking at for the last 2.5 years at this point in time. And this gives a nice little pre-COVID and post-COVID snapshot of the work for telehealth. So with that, so we were given a pot of funding to go through and provide a pilot program. And part of the reason for this was we were trying to showcase the need and the collaborative efforts that are already happening in our state between our community-based mental health centers and our local education agencies and school districts. As we're doing that, one of the things that is really interesting about our state, and just kind of a small snapshot of our state, we have the 11th largest geographical size, and about 80% of our population actually lives in a very small region along the part of northern Utah. So there's a large pocket of people who live in rural areas and frontier areas in our state, but there's also a huge need as it relates to the smaller areas as well. So as we're looking at some of the ways that technology can help overcome and these different access and barrier issues, we're really looking at things as it relates to telehealth and apps and just different types of emerging technologies. Within that, one of the things that we're looking at is the importance of being comprehensive as a state system and utilizing our areas of expertise as this relates to the individuals who have the expertise in mental health versus the individuals who have the expertise with things like the education system. With kids, it's extremely important, especially because I'm sure everybody is aware, but most kids are seen regularly in a school, although COVID definitely threw in a lovely wrench into that situation. So I mentioned we had a fund in our general session in 2018. Our House Bill 308 provided a pilot fund that we were able to use. And we had some discretion to how we utilized it. And what we decided to do was provide 2 pilots and focus one pilot on a very urban setting and one pilot on one of our more rural settings. So as we were looking at this, we really wanted to see how we can increase access to services for kids and families, and also if it's really possible for us to reduce the cost as we're trying to provide these services to youth. Within this, we also were curious as we're looking at things like best practices for telehealth services, the best technology, or rather maybe some technologies that are difficult to use, or technologies that have some barriers to them. And then also some things that are really needed for the future as we're trying to really push forward with understanding what is going to be helpful for kids and families to access services. And I'm fairly heavily focused on kids services, but I will say there is a large amount of this that I think can be applied to adults, minus the education side of working with a school. So within our pilots, we selected Bear River Mental Health and Wasatch Behavioral Health. And for our state, Bear River Mental Health is our northern three most counties. Those three most counties include areas of our state that include places like Bear Lake. If anybody's been there, there are a couple of very difficult canyons to traverse as well in those areas. Sardine Canyon and Logan Canyon are two areas that in the wintertime are near impossible to traverse safely. They often get shut down because of snow. They also present quite the transportation issues when it comes to accessing services in the more populated areas in those communities. As I mentioned, so there's three main school districts that we worked with in the Bear River area, Box Elder School District, Cache County School District, and Rich County School District. And Rich is our most rural school district within that area. That is the area where it really takes the longest amount of time to get there. There's a smaller city that is in that area. They have less access to direct services than the other two county areas. And with that, one of the things that we were looking at too is we provided some access to a platform. It was called In Touch at the time. I think it's been purchased by Teladoc. All of these companies, as I'm sure most of you know, get purchased and sold like crazy, especially with the last year of how things have gone. We were actually offering that as a department to providers within our networks to ensure that this was something that was available as it was necessary. For our urban area, Wasatch Behavioral Health, it was really an urban focus. They have three school districts, and they actually have the largest population of children in our state and out of our counties, which is really important because our state actually is comprised of about 30% population under the age of 18. And in that county, it's actually a little higher percentage, which is really important as we're trying to find better access points and find ways to utilize technology better. They utilized our InTouch platform as well, but they also decided to try out the Zoom telehealth platform, which I think there were some pros and cons to both of those. And I'll get into that in a little bit. So within this, as we're just kind of focusing on what we were able to see, these numbers seem a little, I'll admit, they seem a little low. And part of that is because of the first year of services. So the entire first year of services happened before COVID had been any kind of issue for anybody. So within the first year, the rural area, the rural pilot happened to have a fairly large buy-in where the districts, where the local mental health center, they were able to see the importance of the work and they wanted to really utilize it, especially to access services where it was difficult to, whether it was send a clinician or a team up regularly, or whether it was just difficult for a parent or a family to access services that didn't take hours, an hour or two to actually get there. That was an interesting topic, and I'll talk a little bit more about some of the barriers that we kind of faced with that in a second. We were able to receive or provide services directly with this funding for 184 total students and then 49 schools over the 2 years. The majority of those students were actually served in the second year of the pilot. But these were some of our collected outcomes that we were actually able to look at. And there were some interesting things because we actually do a large number of provider-based services that are traditional in person with school district participation as well. And one of the difficulties within some of this was trying to compare these results, as sometimes it might seem like they're apples to apples, but there's some challenges that make it a little bit more complicated. Grade point averages and really those kind of academic scores were probably the easiest. And we saw a 16% increase in individuals who received the telehealth pilot. Within our regular traditional based services, we see a smaller increase typically, and this was over the same time period. And one thing to note within that data is that there's also a higher number of individuals who are served in that traditional setting. The youth outcome questionnaire is actually something that we use to measure. It's a validated tool that we use to measure various symptomology reduction. And we saw a 12.4% symptom reduction for the kids who received telehealth. Versus a 22% decrease in kids who receive traditional services. I think the one of the key things that we're really looking at is, does telehealth really help in the same kind of capacity? And this was reaffirming to showcase that kids who do receive these services are still able to show improvement and to reduce their symptoms of whatever is going on. So here's some obstacles that we kind of ran into at first. So the first issue that we actually ran into was an urban-rural bias. The urban bias is probably the biggest part of this, and it's this idea that telehealth services are only applicable for individuals who live in our rural or frontier settings. It was the idea that if I live within 15 minutes of a center, or if there is someone who is available to be in our building, why would we want to utilize telehealth? And that was a big reason why within our Wasatch Behavioral Health pilot, we saw some lower numbers in the first year. Those issues were very interesting because we strategized ways to work on that. And those strategies included a number of community meetings and stakeholder meetings. We talked with the programs about ways that they could increase or maybe look at their alternative methods for services, since most of them already had these services within the school. And then also ways to just utilize the funding to have an alternative source for telehealth services. It really was an issue that we also saw within our other centers, and we were expecting this, but we really wanted to see if an urban area could provide the telehealth services in the same capacity as a rural area. The other thing that we saw was parent and youth buy-in. In the first year of this, there was a little bit harder buy-in, especially from the urban area where parents were a little concerned that they were just sat in front of a computer screen, similar to the way we're all sat in front of a computer screen right now, and the ability to actually utilize services effectively. The other thing was professional buy-in. I will say that the first year specifically, and we had seen this prior to that first year of the pilot, a lot of professionals were of the mindset that social work and behavioral health components can only really truly work in a traditional face-to-face instance. And we had a pretty uphill battle, and we actually utilized resources, including some of our regional centers, to help with technical assistance for telehealth services to ensure that, yes, these are things that can be done in non-traditional ways. These are ways that we can really help reach kids where they are at. And ultimately, it was beneficial. So COVID is listed as an obstacle, but it was also kind of an opportunity. So with COVID, we were really focused on this idea that all kids need to still receive services, but how do we do that? And COVID disrupted in-base school services and traditional service for every single kid in the state of Utah. So as we were looking at that, the conversation was then shifted to, is this a possibility for utilizing these telehealth services more effectively? COVID-19 also obviously disrupted mental health treatment itself. Our public system especially, was able to do very similar work to what Kristen shared, where we had a very large uptake and really that flexibility and responsiveness to utilize more telehealth services. But that leads kind of into the successes, and I kind of mentioned this within the COVID response. So this is really interesting because a lot of this deals, I think, directly with the COVID response. So on the right side of the screen, you'll just see the general number of telehealth services that were provided and the number of youth who received those services. We had a very few number of kids provided services in our state fiscal year 17, 18, and 19. In our fiscal year 20, that's when all of COVID decided to happen. And we had a large increase with 8,777 kids who received any type of telehealth-based service. That could have been a medication management service. It could have been direct therapy. It could have been family therapy. It could have been case management. This was really just based on the continuum of care that is offered throughout our state. That is the overall number. And one of the areas that's been really beneficial is actually within the pilot site. So as we saw COVID hit, we saw this shift, and there were actually 3,348 telehealth services conducted during the pilot site years. And those are the number of services, so not the number of youth served, but those are the number of accessible services that were provided that otherwise wouldn't have been provided to these kids given the need for telehealth. I mentioned the COVID-19 response. COVID-19 actually allowed these two centers to shift very quickly. They were actually able to be two of the more quickly shifting centers in our state. On top of that, I think it really presented an opportunity for them to really partner with the schools and say, look, we can actually provide these services even though your kids aren't being seen directly face-to-face in schools. We can still have that be an available option. The other thing too is it meant, as I mentioned, with the number of services, there was an increased access to the continuum of care. I think one thing that's really difficult is many providers have historically tended to use telehealth as a means for medication management, especially in the children's side. In our state, we have seen a huge need for that since we don't have a large number of board certified psychiatrists, especially in our rural areas. So it's been historically used for things like that, but what now it provides a need for the entire continuum of care, which has been extremely beneficial. The other thing that I'll highlight too, we were able to really have some great cost savings in regard to what was used for travel expenses and clinician time. So we were able to break down that the average cost for a client served in 2019 was about $3,500, whereas the telehealth pilot average was about $2,000 per youth. This is obviously beneficial as it presents a way to utilize services in a much more efficient manner. But one thing that I think is also important to know is that this, and this is a conversation I continuously have, but telehealth is beneficial for kids, for some kids and not all kids. And I think when I've showcased this number, this cost savings, I think I've seen people get some big eyes as it relates to serving all kids with telehealth. And unfortunately, it just can't be the case. Although it is definitely a tool that can and should be utilized as we're looking at the needs moving forward. So some of the things as well that we're looking at with policies and procedures, we really looked into best practice standards. We got some TA from National Council of Behavioral Health. We also spoke with the National Consortium of Telehealth Resource Centers. We got some technical assistance from them, and we were able to pass that along to our 2 pilot sites. We also were really focused on the privacy and confidentiality needed. So things regarding federal policy with HIPAA, with high tech, and because these services were being provided in school settings, really the understanding of FERPA and our version in Utah, the URPA, which is the Privacy Act for kids in schools. We really focused on making sure that from a procedural standpoint, we had the right contracts and MOUs in place in order to have these services provided in these settings. I think there was a difficulty with some of the schools understanding why we needed to have these things in place, and a lot of it boils down to the privacy and confidentiality necessary. The other thing that we really were looking at from a policy perspective is, so our state is fairly lucky. We had Medicaid already covering all of these types of services that were available. And then COVID-19 with some of the looser restrictions and guidelines that Stuart mentioned were also very helpful in just continuing and increasing the capacity and the workflow. One thing that I will say though, is that we do hope to continue to see these restrictions loosened. I think telehealth is something that we have witnessed to be very beneficial. But if there are, whether it be private or public insurances that are having shifts in the way that they're providing or paying for these services, it will really present a barrier from a professional standpoint. And with that, I will go to questions.
Well, thank you so much. Those are 3 really interesting presentations, and we do have some questions that it would be great if you could address. First to you, Stuart. You mentioned that there was a congressional hearing on the future of telehealth in Medicare that happened just this week. And I know that the chair of that subcommittee also came out publicly in support of making telehealth permanent, and said that a lot of the previous policies on this were outdated. Do you have any information yet about the hearing and what the next steps might be on that? Unmute. There you go.
I'm sorry, I unmuted my phone, but I didn't unmute on the
No worries.
program. There are a number of bills in. In fact, there were a number of bills in at the end of last session as well. As you indicated, Chairman Eshu stated very strongly that she wants to see most, if not all, of those telehealth flexibilities implemented on a permanent basis. The one witness that I mentioned emphasized that it's important to get the infrastructure down and in place. I don't think that can be done in 2 years, but the COVID relief bill, excuse me, does have a number of provisions in it providing for funding for grants for telehealth. There's 140 million for telehealth infrastructure for Native Americans. There's 500 million for telehealth capabilities, and including underlying structure for rural healthcare facilities. And there's 30 million for substance abuse and 50 million for local behavioral health needs, including crisis services. So there's going to be some money available to broaden those broadband services and make them available to folks in rural and frontier areas. I don't know that we can expect all of that to happen in a year or 2 years, but I do know that Congress is very interested in making this permanent.
Right, thank you. It sounds like this is the time where the opportunity is to move this forward. And my other question for you is that, there's so much of this that's very explicit in changes around Medicare. Do any of those ultimately have some impact on Medicaid? Or are there other things that are going on in Medicaid that is often more relevant for the youth and family population that most of us are serving?
Well, most of the waivers that were issued were interpreted as applying equally to Medicaid and Medicare, and including the audio only. I think the Medicare changes become most relevant for dual eligibles, individuals that would be covered under their Medicaid and Medicare programs, or where their Medicaid programs fund services under the Medicare program. But there does appear to be, we've got a bifurcated system right now, but there does appear to be an interest in making sure that there's a level playing field on telehealth across both programs and in private insurance as well. There was one question that was raised about, and I wanted to jump in on it, the concern about telehealth services to provided to children, and how you deal with the parents being present in the room. So that's the other side of the benefit of telehealth for children. Yes, you do get to see how they interact with their parents, but you may not necessarily want to see them interacting with their parents throughout the session. You probably don't. And it was an issue that was raised by a number of respondents. I did not see a solution suggested.
Okay, all right. Another big issue that's come up and was raised by a number of you, and also in relation to that hearing, was the issue around disparities, and that given that there are communities and populations that lack access to technology, are more likely to lack access to high-speed internet and other technology, is telehealth, could it be a strategy that actually exacerbates some of the disproportionalities and disparities we already have? And if that's the case, what can be done to try to present that? So let me open that up. Eric, Kristen, do you, either of you, both of you, have some thoughts on that?
So Eric may have some more specifics based on working with those particular providers. I just echo that it's a concern, and anecdotally, what we've heard from providers in Louisiana is that fortunately, most families do seem to have a device that's usable what the difficulty is having, sufficient broadband, sufficient, minutes to use for telehealth. We've been able to, in kind of, one-off situations, we've been able to get some assistance from our managed care organizations, have provided, both devices and data for families who are in need of telehealth services. So it certainly is a concern, and we've sort of piecemealed some things together in order to address it for families.
And I can add from our perspective. So in our state, we are actually very fortunate to have some pretty high level of broadband access numbers. I think we consistently rank as a state in the top 10 in that category. But one thing that I will say that we have been doing is we've really been trying to work both at a local level and with our State Board of Education, as there are ways to, I think, leverage some technology assistance in those capacities. We have, it's called the Utah UETN, Utah Education Telehealth Network, which provides broadband access to all of our local schools and school districts throughout our state. That is actually something that we've been looking at. We work on a local level to make sure that it can be leveraged, and having telehealth services provided in conjunction with some of those community partners can be extremely beneficial, because one thing that we've noticed is with when it comes to things like stigma and access, if we are able to have an area like a school, which is a little bit more friendly as it pertains to things like mental health stigma, it allows for more people to be willing to attend. I will say that's not a solution to the entire problem. I think cultural disparities, racial disparities, et cetera, are an ongoing issue. And one of the areas that it's a major concern for our state is actually related to the ability to access like translation type services and things like that, because I think having telehealth services is beneficial, but if you don't have the ability to have someone who can translate when it comes to other languages, it still becomes an issue. And then also on our tribal reservations, we also have some concerns because people live very far away from the infrastructure necessary for a lot of these types of services. So I don't know if there's a specific answer for whether telehealth can or can't be a problem, but I do think it can be part of a solution. I think we just have to be also very creative with the community partners that we're working with. Ultimately, the foundation of all of this is based on incongruency, and it makes it a challenge.
Beth, let me add that the Congress included language in the mental health block grant funding authority for 2021 that mandates that the state agencies report what they are doing to address diversity for both ethnic and racial diversity. And so there will be an onus on the state agencies to find ways to ensure that minorities are being served at an equal level with other services recipients.
Okay, great. Getting back to that issue about children having a private setting to be for a conversation as opposed to being required to talk with the family in the room. One solution that was raised is that if someone happens to walk in the room and you can't see it, is to have a signal word or a sign to notify you that somebody's entered the room so the conversation can change. April brought that up, and Cassandra also mentioned that, wait, that's to the other topic, but that was an interesting solution around the privacy issue, that there might be some kind of a signal that could be arranged between the young person and then the provider to account for something like that. If anybody has other ideas about something like that, put them in the chat, and we'll share those with everyone else. Around the disparity issue and the access to internet, Cassandra made a comment that some providers are offering internet services that wait a second, I've just lost that. I'm sorry. Some providers are offering internet services and are going to start a data cap and charge additional costs. Is there something that government is doing or can do to regulate the cost that people might be faced with soon? Are any of you aware of any efforts to address that, data caps and the cost to individuals for using internet broadband services? And is anybody trying to assist them with that?
I think the only thing that I can say is there were some net neutrality concerns that were taken away during the last administration. And I know there are a lot of technology firms and agencies and companies like Apple and Microsoft and such who are really interested in ensuring that net neutrality is kind of placed back. I think the net neutrality, the loosening of net neutrality is really allowed for companies. So I'll speak just from personal experience. Comcast in my area has instituted a data cap that before was just a data cap that didn't do anything. And now if I go over my data allowance, I think it's like $50 every gigabyte that I've charged. And it kind of makes a ridiculous amount of money for a bill. That is something that is really something we all utilize on a daily basis, especially through the pandemic. I don't have any further ideas on any of that or knowledge of it. I just, through just my interest in technology, I know a lot about the net neutrality pieces.
Thanks, Eric. Anybody else have any thoughts on that? Okay. Given that there are limited resources for bilingual clinicians, is anyone aware of efforts to utilize clinicians across state lines or other creative ways of finding bilingual clinicians that can help with language access?
Well, the waivers allowed for the use of providers across state lines, of course, and that was not only in the province of telehealth, but just generally. So I suppose that if you're looking to make that permanent, you need to contact your member of Congress and let them know that it was a valuable change to the Medicaid and Medicare law.
Okay, great.
I'll say from a local perspective, we've actually had some of our local legislators pushing bills that would really force us to look at more interstate compacts with licensures to ensure that those can transfer more readily. I know it's a lot more readily available for MDs and psychiatrists than it is for mental health therapists, but that's something that we've also been looking at as well from a legislative perspective.
Okay, great, thank you. A big topic that was mentioned by quite a number of people is around this issue of Zoom fatigue, both for young people and for providers, and burnout from that perspective. One question was, do you think there's a chance that people would be more acclimated to virtual communication and the rates of burnout and fatigue might decrease? How much of this do we think is pushback around virtual services, given the novelty of the service? With youth going to virtual school, is burnout and reluctance something that people are seeing, particularly for sessions in the evening? So this whole issue around burnout, both for young people and families, I'm sure, and for providers, is one that clearly a lot of people are thinking about. Can each of you maybe address that whole issue?
I can go, and I don't have great answers, but this is giving me great ideas for things that we should look at next. Early in the pandemic, we did a lot of, surveying providers and gathering information, data anecdotal around what was working for providers, what wasn't, what they needed in order to do this with kids and families. I feel like it's time for some new, reaching out to our providers, a year in. I'm curious to see what our providers are experiencing. Are they certainly aren't doing 100% telehealth anymore. So is that helping with the level of Zoom fatigue on the behalf of providers, given that they don't have to use telehealth for every client like we felt like they needed to early on. at this point, if providers are doing telehealth and if clients are using telehealth as a delivery modality, it's not a completely free will type of choice. There certainly are safety factors and considerations, and some folks can't or won't do in-person visits at this point. But it's more of a choice than it was before. And so folks are making a decision at this point to use telehealth versus in-person at some level. So who's making that choice and why, and who is still choosing to continue to do telehealth because it's working for them or because they have to. So I think that is actually something that we might want to reach out to our providers and learn more about what their experience is right now. And then I think our response would be to bring providers together again, as we did early in the pandemic, to meet with experts who have good tips and tricks for how to respond to this. And also to hear from each other, to hear from their peer providers around, this is what I was experiencing and this is how I'm responding, or here's a strategy I tried, or yeah, I also really struggle with this. So that's probably going to be our response at the state agency level, is to try to learn a little more from our providers about what they're experiencing right now, and then try to kind of push out another round of strategies and supports.
I suspect there's an economic incentive to continuing to use telehealth as well, as long as the telehealth services are being paid at the same level as non-telehealth services. It's no greater money, but it's a reduced cost for the provider. And I would imagine that's an incentive to continue to use the service.
I think just to add to what has been said already, one of the things we've been seeing is the same kind of trend that Kristen is speaking about, where more and more providers are going to kind of more hybrid type models where they don't have to be solely on Zoom. One thing that I think is really crucial, though, is having that ability for flexibility and choice for the individuals receiving services, because I think at the end of the day, at least from my perspective, if we've seen benefit for clients and individuals receiving services, and then we shut off that flexibility, it definitely can lead to a decrease in some of those who were very comfortable receiving that. And it goes back to what Stuart's saying as well. If there's no financial flexibility either, then it kind of definitely shuts off the valve. But
yeah. And I think one of the, in terms of looking at what services this works for best or where there might be barriers, what about services like mobile response and stabilization or in-home intensive mental health treatment? Those services which were really dependent on outreach, how have those been impacted? And are there mechanisms for continuing some of that, at least in crisis situations, or how is that being handled in your states, Eric and Kristen?
So in Louisiana, it's speaking to those intensive in-home family-based programs like multi-systemic therapy, like functional family therapy. Those we anticipate at some point are going to go back to no telehealth delivery, because the rule change that we made to allow those via telehealth is considered temporary. We really do think of those services as services that are best delivered when you're sitting in somebody's living room.
Right.
So at some point that's going to go back to fully in person. We're not trying to shut off the valve quickly by any means. We're trying to take our time with this and allow flexibility for a while to make sure that families can continue to get the services and get what they need. In my presentation, you saw my graph of therapy services. The graph of those intensive in-home services looks pretty similar, honestly. They all similarly jumped from no telehealth to a lot of telehealth to kind of a little more of a balance of in-person. I expect those services will move back to in-person more quickly, and they have. We moved back to more in-person delivery more quickly than the more kind of standard clinic-based therapy services. But we're going to allow those to kind of inch back up to all in person, slowly over time.
So I'll echo a little bit of what Kristen's saying. I think we have seen that kind of ebb and flow as well. Within our state system, we actually already have a number of providers who are providing some telehealth-based crisis type services prior. Granted, the capacity was like someone would go to a rural hospital and then the crisis worker wouldn't necessarily be located directly in that hospital or in that facility. We are consistently trying to navigate the needs of our rural areas. We've had a large boon to our infrastructure for our mobile crisis and our crisis teams in general across our state. But one of the challenges is when someone is literally 3 hours away from the closest provider, and how we can do a lot of that work. So we've actually relied heavily in the past on some of the telephonic audio only types of communication. And I think this telehealth has been, at the very least, a method to really help with an additional form to communicate. I mean, it's not perfect by any means, but it's something. And we've also tried to utilize some text-based crisis utilization tools, especially on the kids side. We have an app in the app stores called Safe UT that allows for some of that ability to do text-based crisis discussions and counseling. But I think that it's very much going to be kind of be flexible and play it by ear as we need to go and shift things for our state. It is very heavily traditionally in person along the Wasatch Front, our main populous area, though.
Eric, thank you.
I would think that it could be best be used in the follow-up. We've seen a number of studies indicating that crisis services and hotline services are most effective when there's follow-up afterwards. And I would think using telehealth to do that follow-up would make those services even more effective.
Great. Eric, would you mind putting in the chat the text-based service that you're using? And I think that in general, people would really benefit from resources, particularly about mobile crisis and how that kind of thing works in a virtual environment. And around that, what kinds of technical assistance might be available? You mentioned some of the training that you're offering, Kristen. I don't know if people might be able to get more information about that, that you might be able to put in the chat, or we could put in a follow-up email, whether they can learn more about that training and if there's any way they could have access to some of that. And if you or others in the audience have information about particular resources that might be helpful to others, put those in the chat and we can disseminate that as well. I guess, another question really is what is needed from the federal government or from state governments more broadly that can help organizations and agencies and providers, meet the needs through telehealth services. Are you aware, what are those kinds of things that you think might be needed? One of the questions was how can federal efforts assist in states? How do you think that, state government, federal government can be more helpful to facilitate this? Any of you?
Money.
Money.
I mean, just to piggyback on what Stuart said, the funding that we're using to help providers with their telehealth platforms is pretty limited, and there's a lot of restrictions on how we can use it. So, I need to learn more about some of the information Stuart was presenting on new, financial assistance opportunities for providers to fund telehealth platforms, because the stuff we were able to do with the funding that we have was relatively small. And I'd be interested in looking at how we can get that type of financial support out to more providers and also to families. The funding we had didn't allow us to use it for devices or data for families. So that was a gap that we experienced we had to figure out ways to fill that for families.
I'll echo the funding and flexibility of the funding. And the other thing I think goes back to one of the questions earlier. I think any support for increasing the capacity and availability of internet for people, and the internet that is high speed. that I think is probably the biggest help for any of this, especially given the route our world is going and the needs of our world today, not just with education and like kids in schooling, but in general with any type of this healthcare and the work we're all doing from home.
Great.
I do think, and I'm sorry I was a bit glib earlier, but I do think that the administration could be very helpful by jawboning insurers to ensure that these services are covered and are covered and reimbursed at the same level as face-to-face services, and that is something that NASHPD asked of the incoming administration when right before I left there.
Right. And I do know that there are places that have used various kinds of grant funding to purchase devices for youth and families and such. I'm not sure what those are, and maybe we, if any of you have any thoughts or are aware of what some of those grants might be, let us know that, and we can put that in the follow-up email as well. So we're getting towards the end. I'd like to offer each of you a chance to offer any final thoughts or comments that you'd like to make before we close.
I'll start, and I'll just say telehealth is a wonderful service. It's I think it's part of the solution, not the only solution. And I think it's something that we should be utilizing much more effectively just across the service continuum.
Okay. Kristen, any thoughts?
Eric said what I was going to say, that this has been an incredible experiment in a lot of ways. And echoing what Eric said earlier around, in some ways, provided an opportunity that I'm sure felt like a forced march for providers and clients in terms of having to jump into telehealth. And at the same time, it's sort of forced and allowed us to discover some of the things that telehealth can do that we didn't really know before. So I think there are ways going forward to use this as an opportunity, certainly strive for more balance in-person versus telehealth and figuring out kind of what works best for what situations and what folks. But I think there's a lot of opportunities to use this more going forward.
Great, thank you. Stuart, last word.
I agree with what both Kristen and Eric said. I think the pathway's wide open now. I don't suspect we'll be going backwards. It's just a matter of finding the funding to keep going forwards.
Great. So in closing, I'd like to say thank you to our outstanding presenters, Stuart, Kristen, Eric, for sharing their expertise and their strategies with us. And thank you to our interpreters, Kelly and Noel. We appreciate it very much. And thanks to all of you for joining us for this segment of Training Institutes Live. We hope you'll take advantage of the wellness break before you join the next set of workshops that'll begin at 3:30. The link for that is in the chat. And if you haven't registered for one of the 3:30 sessions, it's not too late. The link for that is also in the chat, and you can use that link to register for future workshops always. And we'd also very much appreciate if you could take just a couple of moments to complete the evaluation for this workshop that's in the chat. We do take your feedback very seriously, and it will help us to shape the upcoming workshops in the series. So again, thanks to all of you for joining us today. We look forward to seeing you after the break and on the first Thursday of every month for Training Institutes Live. Thank you.